Hello, my name is Yejun Hong. I'm a medical student in the University of Calgary, and we are here to explain myasthenia gravis. Ophthalmology and neurology are highly related specialties. The eye is a sensory organ that perceives light, and this is also connected to the nervous system. It is situated very close to the brain, so that any diseases in the brain can directly affect the eyes as well. And the eye is innervated by 4 cranial nerves out of 12. 2 is for detecting light, and 3, 4, and 6 are responsible for the motility of the eye. The retina itself has a neurosensory layer that becomes the optic nerve as it exits the eye. Specifically to demonstrate the link between the two specialties, there is myasthenia gravis, which is an autoimmune neuromuscular syndrome that affects the eyes. Myasthenia gravis affects the neuromuscular junction, and specifically the acetylcholine receptors in the postsynaptic membrane. This results in muscle weakness and easy fatigability. Let's observe more in the extraocular muscles of the eye, which will be highly relevant for the purpose of this presentation. Other than the muscle that controls the eyelid, the levator palpebrae superioris, there are 6 muscles that insert into the eye: the superior rectus, inferior rectus, medial rectus, and lateral rectus, as well as superior and inferior obliques. The actions of these muscles can be memorized by SINRAD, S-I-N, and R-A-D. S-I-N means that the superior, so any muscles with the word superior in it, intorts. So naturally, all the muscles inferior will extort the eye. And for rad means rectus muscles adduct, and oblique muscles will abduct. Okay. So for examples, for superior obliques, the superior oblique will intort the eye, and because it's an oblique, it will abduct the eye. The lateral and the medial rectus muscles don't apply to this acronym, and their actions are simply for medial rectus to adduct the eye, and lateral rectus abduct the eye. Myasthenia gravis presents with an autoantibody to the acetylcholine receptor on the surface of a muscle fiber. So no matter how much the nerve fiber produces and releases the acetylcholine, there is no way for the muscle to receive those neurotransmitters with the signals to activate. So all the muscle activation will be inhibited. Female patients having a positive family history of myasthenia gravis or having other autoimmune disease like scleroderma and lupus and rheumatoid arthritis raises the risk of the individual having myasthenia gravis. Other examples include thymoma. Thymoma in a patient makes it so much more likely that myasthenia gravis is also present. And multiple sclerosis is a neurologic disorder that can also coexist frequently with myasthenia gravis. The symptoms of myasthenia gravis is fatigability. So towards the end of the day, it gets harder and harder to move the muscles around. And for the eye specifically, the early ophthalmic signs of myasthenia gravis is binocular diplopia due to the fatigue of the extraocular muscles, as well as ptosis due to the fatigability of the levator palpebrae superioris. Dysarthria and dysphagia can also develop from this disease. Bulbar muscles fatigue out, leading to drooling and dysphagia, shortness of breath in advanced cases, and weakness of neck, extremities, and trunk can develop in advanced cases as well. As discussed, the signs you may be able to notice with MG is worse with fatigue and asymmetric ptosis, because this is a neuromuscular junction disorder. It dissipates in an asymmetric fashion, and there's a variable limitation of extraocular movement. The muscles that it affects is seemingly random and dispersed according to how the autoantibody reaches the target. Hypotropia can be present, negative force ductions, and orbicularis oculi weakness can present in the patient as well, and Cogan's lid twitch. Complications of MG include myasthenia crisis. This is extreme muscle weakness, including the diaphragm. This is life-threatening because obviously you need the diaphragm to breathe, and therefore the body has a lot of fail-safes to prevent the diaphragm from failing. This can occur from lack of treatment and from exposure to triggers like respiratory infections, stress, or surgery. Differential diagnosis includes the palsy of different cranial nerves of the extraocular movement, Miller-Fisher variant of the Guillain-Barré syndrome, botulism, which is a toxin that freezes the muscles, thyroid eye disease, multiple sclerosis, internuclear ophthalmoplegia. We have covered this in another video, so feel free to check that out. CPEO, which is a series of 5 diseases, which we've also covered in other playlists. And idiopathic orbital inflammation is also possible. So do a complete ophthalmic and neurologic as well as systemic history when suspecting myasthenia gravis. Look for ptosis and conduct a cranial nerve exam with the extraocular movement. Ice pack test to look for any relief of fatigue of the upper eyelid may determine the diagnosis. And hydrophonium chloride test is not being done very often nowadays because of its risk to the heart. Anti-ACH receptor antibody tests is the gold standard test to determine that the patient has myasthenia gravis. We should also look for TSH and T4, T3 and TSI to rule out any thyroid abnormalities. Electromyogram, nerve conduction study, and single fiber electromyography for orbicularis muscles can be attained. Chest CT is done to see if the patient has thymoma. One of the therapy for myasthenia gravis is thymectomy. For mild symptoms of myasthenia gravis, there is no treatment, just monitoring. Oral cholinesterase inhibitor, like pyridostigmine, giving 60 milligrams per oral, 3 to 4 times a day, can lead to improvements, and side effects include cramping and diarrhea. For the remission of symptoms, apply short oral steroids, short-acting. So prednisone 20 to 100 milligrams per oral per day. Check the CBC and blood glucose and lipids and chest radiographs before giving the steroids, because it tends to raise the blood glucose and inhibit the body's immune system, so that if there's any pathologies in the lungs like pneumonia or even cancer, they can progress rapidly with the administration of steroids. Long-term steroids should have regular checkups with height, bone mineral density to take actions if there's an appearance of osteoporosis beginning. So every 1 to 3 years, the patient should attain that. PPIs for side effect peptic ulcer disease, and calcium vitamin D bisphosphonate teriparatide for osteoporosis can be considered for long-term systemic steroids. For immunosuppressed patients, use the steroid-sparing immunomodulatory therapy like Cellcept and methotrexate. For severe weakness, consider a plasmapheresis to filter out those autoantibodies. Give IV immunoglobulin and rituximab. Thymectomy is done if thymoma is found. If there are any concurrent thyroid disorders, because autoimmune disorders come together as a group. And for myasthenia crisis, check if the patient needs intubation. For patients with diplopia, surgical tape and this occlusion therapy can be helpful with the correction. Myasthenia gravis is a chronic and progressive disease, and the prognosis is variable. If there's an isolated ocular presentation without any systemic ones, the prognosis is considered good. So here is the link slide again. Hopefully we were able to convince you that myasthenia gravis is a representative disorder that connects ophthalmology and neurology. This is the summary slide of everything we talked about. And this is the reference. So thank you for watching this video.